Hello, future nurses. My name is Mr. Pacrease, and I am the ultimate hidden multitasker of your abdominal cavity. I am a soft, elongated, yellowish organ measuring about 6 inches long, shaped a bit like a fish or a tadpole. I sit quietly tucked away deep in your upper abdomen, lying horizontally right behind your stomach, and cradled in the C-shaped curve of the duodenum, the first part of your small intestine. In your nursing lectures and clinical rotations, you will hear my structures and disorders described using the root word pancreato, like pancreatitis, or a pancreatoduodenectomy. If you see that term, it's all about me. What makes me uniquely fascinating and highly tested on your exams is my dual personality. I am both an exocrine gland delivering digestive juices through a duct and an endocrine gland secreting vital hormones directly into the bloodstream. I simultaneously manage how you digest your lunch and how your cells utilize glucose for energy. 1. The exocrine factory, the digestive assistant. About 99% of my total cellular body is dedicated to my exocrine function. My job here is to help your digestive tract break down large food molecules into nutrients your body can actually absorb. The acinar cells. My exocrine tissue is arranged in tiny grape-like clusters called acini. These acinar cells manufacture and secrete a potent cocktail called pancreatic juice. The delivery route. This juice flows out of the acini into a network of tubes that merge into the main pancreatic duct. This duct joins forces with the common bile duct from the liver and gallbladder, emptying directly into the duodenum through a small doorway called the ampulla of Vata. The powerhouse enzymes. My pancreatic juice contains 3 major enzymes that handle the heavy lifting of chemical digestion. Amylase breaks down complex carbohydrates and starches into simple sugars. Lipase shreds dietary fats, lipids, into fatty acids and glycerol. Proteases, trypsin and chymotrypsin, break down complex proteins into basic amino acids. The safety mechanism. Because your pancreas is made entirely of protein, these proteases are incredibly dangerous. If they activated inside me, they would digest me alive. Therefore, my acinar cells secrete them in an inactive form like trypsinogen. They only wake up and become active once they safely reach the interior of the duodenum. The bicarbonate buffer, my exocrine juice, also packs a massive amount of sodium bicarbonate, NaHTO3, which is highly alkaline, basic. When chyme, food mashed with intense hydrochloric stomach acid, squirts out of the stomach into the duodenum, it threatens to burn the intestinal lining. I flood the duodenum with bicarbonate juice to instantly neutralize that burning stomach acid, raising the pH to an optimal, slightly alkaline environment where digestive enzymes can work efficiently. 2. The endocrine factory, the sugar controller. While it only makes up about 1% of my total tissue, my endocrine function is what keeps your patient out of a diabetic coma. Scattered throughout my exocrine tissue like tiny islands in an ocean are microscopic clusters of endocrine cells called the islets of Langerhans. These islands secrete hormones directly into the passing bloodstream to tightly regulate your blood glucose levels. You must memorize my 2 primary regulatory cell types for your pharmacology and metabolic exams. Alpha cells, the sugar raisers, the hormone, glucagon. The trigger, released in response to hypoglycemia, low blood glucose, like when your patient is fasting between meals. The action, glucagon travels straight to the liver and commands it to execute glycogenolysis, chopping up stored glycogen blocks into free glucose, and gluconeogenesis, building new glucose from fats and proteins, flooding the bloodstream with sugar to bring energy levels back up to normal. Beta cells, the sugar lowerers, the hormone insulin, the trigger, released in response to hyperglycemia, high blood glucose, like right after your patient eats a carbohydrate-heavy meal. The action, insulin acts as a molecular key. It circulates through the blood, attaches to receptors on your body's cells, especially muscle and fat cells, and unlocks the cell doors to allow glucose to move out of the blood and inside the cells to be burned for energy. It also tells the liver to store excess sugar as glycogen for a rainy day. Common pancreatic diseases and pathologies. When my engines fail, your patient faces acute emergencies or chronic lifelong metabolic disorders. 1. acute pancreatitis, the self-digestion nightmare, an acute severe inflammatory process where my pancreatic digestive enzymes accidentally activate inside my tissue instead of waiting until they reach the duodenum. The cause? Most commonly triggered by a gallstone blocking the ampulla of Vata, causing pancreatic juice to back up and stagnate, or chronic alcohol abuse, which irritates and permeabilizes the ducts. The pathophysiology. The activated proteases begin violently digesting my own living tissue, autodigestion, leading to severe inflammation, bleeding, and localized tissue necrosis. The clinical presentation. The patient will arrive in agonizing sharp pain located in the epigastric region that radiates straight through to their back. They will often find slight relief by sitting up and leaning forward. 2. Diabetes mellitus, the sugar crisis. Type 1. Diabetes, an autoimmune disease where the patient's own T lymphocytes mistakenly attack and permanently destroy my beta cells. Because the beta cells are wiped out, the pancreas produces zero insulin. Without insulin keys, glucose is trapped in the blood, starving the cells while the blood sugar spikes to dangerous heights. These patients require lifelong insulin injections to survive. Type 2 diabetes. The pancreas produces insulin, but over time, due to genetics, obesity, and prolonged high sugar diets, the body's cell doors become rusty and stubborn, a state called insulin resistance. The pancreas tries to compensate by pumping out even more insulin, but eventually, the beta cells burn out from exhaustion. Critical nursing assessments and labs. The pancreatic enzyme lab panel. If you suspect your patient has acute pancreatitis, your highest priority diagnostic evaluation is checking their serum amylase and lipase levels. In acute pancreatitis, these enzymes leak out of my damaged cells directly into the bloodstream, causing their values to skyrocket to 3 times the normal reference limit within hours. Lipase is considered the most specific and accurate indicator of pancreatic damage. The NPO intervention. When caring for a patient with acute pancreatitis, your primary nursing intervention is to make the patient strictly NPO, nothing by mouth, and insert a nasogastric NG tube to low intermittent suction. The rationale: every time a patient smells, tastes, or swallows food, the stomach releases acid, which triggers the duodenum to send a message to the pancreas saying, "Send down the digestive enzymes." By keeping the patient completely NPO, you put the GI tract to sleep, halting the production of pancreatic juices and allowing the inflamed pancreas to rest and heal. The shock warnings, Cullen's and Gray-Turner's signs. In severe cases of hemorrhagic pancreatitis, blood from the auto-digested pancreas can seep through the retroperitoneal tissue spaces. Look closely for Cullen's sign, bluish bruising around the umbilicus, belly button, and Gray-Turner's sign, bruising along the flanks, sides of the abdomen. Seeing these signs is a major nursing alert that the patient is bleeding internally and heading toward hypovolemic shock. Like, follow, share, and comment if you enjoyed the lesson.